Now we'll be talking about chronic constrictive pericarditis, which is CCP. So main feature you have to know, just like the name says, it is pericarditis. There is some problem with the pericardium. What is happening here? You have a very thick, stiff pericardium, which is not allowing the heart to expand to diastole, to fill. So there is filling defect. We call it as diastolic dysfunction. So chronic constrictive pericarditis is nothing but a diastolic dysfunction. So there is thick pericardium. We often use the term rock-like pericardium to make you understand that how thick the pericardium is and how difficult it is for the heart to undergo diastole. That is to fill. So you usually during diastole, the atria empties into the ventricle and the ventricle fills with the blood. But since there is thick pericardium, it is difficult for the heart to expand as the blood reaches the ventricle. So there is diastole dysfunction. So what are the causes of chronic constrictive pericarditis? Causes, when we discuss the first one, you should know that when a patient comes to you, so this is a patient who's coming to you with chronic constrictive pericarditis, main thing you should know about the patient is that he has had many episodes of acute pericarditis, that is relapse. So there has been relapses of acute pericarditis. That's the most common cause. So relapses of acute pericarditis is one of the most common causes for CCP. Chronic occurs after relapses of acute pericarditis. So this is the most common cause. There are other causes as well. The second cause being post-viral. Post-viral, and the most common viral cause you have to think about CCP is starts with C, Coxsackie virus. Also, TB patients can also develop CCP. So most common is anyway your relapses of acute pericarditis. What you have to remember next is the features of chronic constrictive pericarditis. The patient I told you is coming to you. The patient is very lean. He's very lean. He's cachexic. Not very lean. He's cachexic actually. Malnourished. Plus he has ascites. Ascites. He has edema. He has edema. He has ascites, and he has hepatomegaly. So he's cachexic. He has ascites. He has edema, and he has hepatomegaly. So this makes you think of some other disease. You won't think about CCP first in these patients. This patient who's cachexic, has ascites, edema, and hepatomegaly, you mostly think about an abdominal cause, which is nothing but cirrhosis. But so cirrhosis is a differential diagnosis for your chronic constrictive pericarditis. But how do you differentiate chronic constrictive pericarditis from cirrhosis? Is that in cirrhosis, ascites comes later, but in your CCP patient, you get ascites precox. Ascites comes first. Also, the main thing you have to remember is that in chronic constrictive pericarditis, JVP is an element. So cardiovascular disease, obviously JVP will be, this disease JVP will be elevated, which helps us differentiate it from cirrhosis again. So checking JVP actually helps us differentiate CCP from cirrhosis. Now we have made a diagnosis of CCP. What else do you see in this patient? So normally this is your heart. This is your heart. Normally what happens is when there is during inspiration, so when the patient inspires, normal person, when he inspires, during inspiration, what happens? The intrathoracic pressure will fall. This is a normal thing. So this thing, mark it in purple. This is a normal thing. During inspiration, intrathoracic pressure falls. The same thing happens in chronic constrictive pericarditis also. There's fall in intrathoracic pressure. But the difference is that normally when there is inspiration and the falling thoracic pressure will be reaching the chambers of the heart will know about it. But here, because of chronic constrictive pericarditis, because of thick, very thick pericardium that you have, outside things are not known by the inside heart. For chambers, they don't know what is happening outside. So the intrathoracic pressure, which is falling actually outside, is not reaching the chambers. So this pressure transmission is not reaching. Fall in intrathoracic pressure is not transmitted to the chambers of the heart. This is because of the thick pericardium. So what happens? There is something which is abnormal. There is increase in JVP with inspiration. Normally there should be fall in JVP with inspiration. But here there is something abnormal. There is increase in JVP with inspiration in CCP. You call this as Kussmaul sign. Kussmaul sign is positive in CCP, which is increased JVP during inspiration. Normally it should fall, but there is increase. So this is a sign which you get in this disease. So they might ask you what are the other conditions which can cause positive Kussmaul sign. You should also know you get Kussmaul sign positive in restrictive cardiomyopathy. So CCP is very important. Restrictive cardiomyopathy both are very important. The thing that they can ask you is that do you get Kussmaul sign in cardiac tamponade? So cardiac tamponade is also a differential diagnosis. No, you don't get Kussmaul sign in not in cardiac tamponade. You don't get it in cardiac tamponade. Next sign that you have to remember in chronic constrictive pericarditis is that there is pericardial knock. What is pericardial knock? So what is happening in this disease is that the heart is filling, but the heart has to fill. Diastole has to happen, but the diastole is not effectively happening like that of in a normal heart because of thick pericardium here. So there is filling, but only in the first one third. Only in the first one third of the diastole there is filling. So what body tries to do is push, atria tries to do is push all the blood into the ventricle in the first one third. The first one third only filling occurs, and during this first one third itself, all the filling occurs, all filling. So all the filling is occurring, so it's rapid. It has to occur in the first one third because the later part there is no relaxation, so there can't be any filling. Only in the relaxation, that is the first one third, there can be filling. So the next followed by the next 2/3, no filling, no diastole dysfunction. So of the total diastole, only the first one third is actually normal, or you can quite say is that also abnormal because there is rapid filling and all the filling is occurring in that. It's quite abnormal, but it's the only period of diastole where there is filling of the ventricles. So if you draw a graph of that, such that it, this is how you get it, like a square root. That is, this part shows fall in pressure, right? It's fall. So fall in pressure. And this part, the one in yellow, shows rise in pressure in the ventricles because of the thick pericardium. And then what is happening? That is remaining constant. That rise in pressure is remaining just as it was at the topmost point. So the pressure is remaining raised constantly. So there is fall only for a very small, brief amount of time. And that time is our first one third when all the filling occurs. That is rapid filling occurs. Rapid filling occurs. And the remaining part, which you can see where the pressure remains, this is the pressure graph. The pressure remains a rise in. That part, there is no filling, which is the abnormal 2/3. So you get this square root sign here, where there is fall in pressure followed by rise in pressure, which remains constant as such. This is known as square root sign. So square root sign is only seen in chronic constrictive pericarditis. So that I've explained. Why do you call it a square root sign? Now going into JVP, talking about Kussmaul sign, you should talk about JVP as well. So JVP we know is falling with inspiration, but we don't know about the graph of JVP here. We don't know about the X or Y descent, which is actually changing from the normal pattern in chronic constrictive pericarditis. What happens to X descent? What happens to Y descent? Normally, what does X descent mean? Normally, what does X descent mean? So this is normal X descent, normal Y descent. So normally X descent means atrial relaxation, and Y descent normally means atrial emptying into ventricle. That is atrial emptying into ventricle. Atrial can only empty into ventricle, so it's atrial empty. So X descent normally is atrial relaxation, Y descent normally is atrial emptying. What happens? What do you think will happen in chronic constrictive pericarditis? Atria able to relax properly? Can it relax properly? What is happening in the first one third? I told you. First one third there is fall in pressure followed by rise in pressure. So first one third there is fall in pressure, and so there is all the volume from the atria is coming into the ventricle. So atrial relaxation, which is usually happening during atrial diastole, can also not happen much because the very next phase is to push all the blood from the atria into the ventricle. So atrial relaxation is very rapid. It happens very quick. It is very prominent. So atrial relaxation, so the X descent is very prominent. Prominent X descent, or you can call it as rapid X descent. Rapid prominent X descent, you get it in chronic constrictive pericarditis. What about Y descent? Y descent is atrial emptying. Atrial emptying into ventricle. Can the ventricle enlarge like a normal heart? No, because of the very thick pericardium, because of the stiffness of the pericardium, because of the rock-like pericardium, the atria cannot empty into the ventricle, and which means ventricle can't enlarge like a normal heart. The Y descent is also very rapid or very prominent, very sharp, or you can call it as prominent itself. No, prominent, rapid Y descent. So both X descent and Y descent are prominent, rapid, which here is known as Frederick's sign. But X and Y being prominent in CCP. You get it in CCP, Frederick's sign. So what is happening? First one third there is normal filling. Normal filling is rapid filling into the ventricle. So all the blood is tried to be pushed in the first one third itself, like this is square root graph. So what is happening here is all the blood is pushed during the first one third. So there is elevation and equalization of diastolic pressure. Diastolic pressure when? After one third. So pressure is increasing when? And then it's becoming constant when? After this first one third only pressure is increasing. So elevation and equalization of diastolic pressure is occurring, but only after one third. That is very important in CCP. So there is elevation and equalization of diastolic pressure. Diastolic pressure, the heart diastolic pressure is increasing here, but after one third, after all the filling of the ventricle. Do you get pulsus paradoxus here? Pulsus paradoxus is fall in systolic BP more than 10 mmHg with inspiration. So normally with inspiration, there is fall in SPP, but it is not more than 10 mm. It is like 5 to 6, but it never goes beyond 10. It's below 10 mmHg. But when there is fall in SPP more than 10 mmHg with inspiration, we call that as pulsus paradoxus. And where do you get this pulsus paradoxus? You get this in CCP also. So pulsus paradoxus, you get it in CCP, but do all the patients of CCP get pulsus paradoxus? No, only one third patients, not like the first one third of the diastole I'm talking about. Only one third of the patients get pulsus paradoxus in CCP. Next, one important thing you want to mention in the square root is there is something called pericardial knock. You can hear pericardial knock. So this pericardial knock is seen in chronic constrictive pericarditis at what part? Soon after the pressure rises, that is here. Soon after the pressure rises, this part you get as pericardial knock, that is after the that is start of the elevation and equalization of the diastolic pressure, you get the pericardial knock, which you cannot actually differentiate from the third heart sound. So what is the investigation you do for CCP? You have to see the pericardium is thick. You have to see the diastolic dysfunctions. Everything can be seen with MRIs. MRI is the investigation of choice for your CCP. And treatment, what you have to do? So there is only one problem which is causing all of it. All of this is caused by one problem, which is nothing but this thick pericardium. So just remove the thick pericardium. It itself is the answer. So that is remove the problem, pericarditis is the treatment for chronic constrictive pericarditis. So I have told how this can present, the causes, and how it can be differentiated from the liver cirrhosis because of the presence of ascites, cachexia, edema, hepatomegaly. I've told what happens to the pulsus paradoxus. I told what happens to the Kussmaul sign and everything, square root sign and pericardial knock. Everything is